Unseen wounds, forensic indicators of torture when bruising is absent. In forensic pathology, the absence of visible bruising or blood pooling does not mean the absence of violence. Torture methods can be deliberately selected to minimize surface discoloration, or may leave marks that disappear with time, decomposition, or postmortem handling. Experienced examiners therefore turn to deeper, less obvious evidence. Internal injuries, subtle skin changes, histological findings, and the broader investigative context that together can reveal a pattern of inflicted harm. Deep muscle hemorrhages and microtears can be present even when the skin looks intact. Blunt force transmitted through clothing or repeated blows can rupture muscles and produce hemorrhage between tissue planes that is visible only on dissection. Similarly, fractures of ribs, the nasal bones, or the hyoid bone may occur without overlying lacerations, and these injuries strongly suggest compressive or blunt trauma consistent with beating, strangulation, or targeted impact. Organs can bear the imprint of sustained violence. Lacerations or ruptures of the spleen, liver, or kidneys may result from forceful blows to the torso, while pulmonary findings such as edema, contusions, or particulate material in the airways can indicate suffocative techniques, aspiration, or forced ingestion. Fat embolism and other sequelae of severe skeletal or soft tissue trauma are less common, but when present point to high-energy insults inconsistent with ordinary accidents. Skin and subcutaneous tissues offer clues even when classic bruising is absent. Petechial hemorrhages, tiny capillary ruptures most evident on mucous membranes and the eyelids, are a recognized sign of asphyxia or neck compression. Old scars, patterned healed lesions, or subtle hyper or hypopigmented areas can document prior episodes of abuse. Burn injuries from heat, chemicals, or electricity often leave characteristic margins or underlying tissue necrosis that persist after surface healing and are detectable on careful inspection and sampling. Microscopic and histological analysis frequently provides the decisive evidence. Subdermal hemorrhage beneath intact epidermis, focal inflammatory infiltrates, fibrin deposition, and stages of tissue repair can establish timing and mechanism of injury. Nerve degeneration, fibrosis, or focal axonal loss can indicate repeated constrictive or electrical trauma. These findings require targeted sampling and expert interpretation to distinguish ante-mortem trauma from post-mortem artifact. Positional and mechanical forms of torture produce their own pattern of damage. Forced postures can produce joint capsule injuries, chronic ligamentous strain, and pressure-induced muscle necrosis. Prolonged immobilization or tight bindings produce pressure ulcers that may extend to muscle and bone. Evidence of strangulation neck muscle hemorrhage, hyoid fracture, and petechiae may be subtle or localized, and is often easier to confirm when combined with histology and toxicology. Finally, forensic results must be read alongside scene information, witness statements, medical records, and investigative findings. The absence of surface bruising or livor mortis does not invalidate reports of torture. Rather, it necessitates a more thorough, multidisciplinary approach that listens to the body's quieter signals. When internal, microscopic, and contextual evidence converge, they form a coherent narrative capable of countering claims that no visible injury means no violence occurred.